how do you balance everything that's going on? The teaching, efficiency. You could spend hours with a single patient.
Yes.
But you have many others that need to be seen. The early discharges that are prioritized or have to be prioritized,
Right.
et cetera. How do you do it?
Well, I like Dr. Gross' approach and how he does it. Our team does it pretty similar. They usually pre-round, and we usually have rounds around 9:30, 10 o'clock. And I let the medical student or the PGY1, the intern, present the case and come up with their plan. But they usually check with their second year or the third year before presenting to me. And then the third year, I let the third year kind of lead rounds so that they can teach, and I interject at any time if I feel like they're struggling. But I like to point out different things, like it could be just minimal. For instance, like the other day, I said, like, what is the difference between normal saline and lactator ringers, so that they understand what is it that they're giving the patient. Sometimes little things like that we don't go into detail in medical school. We're just told what to do. And if we don't go back and look into it, like, we don't learn about it. So therefore, little things like that I wish I knew when I was an intern, so I pointed out. So those are the things that we usually do. We regroup and we give feedback. I give them feedback on their presentation or how they handle the news to the patient. I also tell them if they have to use like simpler terms and making sure that they tailor it to the patient's literacy. Sometimes we forget about that and use this big medical term. So I tell them sometimes even grab a piece of paper if the patient doesn't understand something that you're telling them. Grab a piece of paper. Nobody's an artist, right? But you can draw a heart, or you can draw the lungs, or something that what is it that they're going, and model it. Sometimes it's just, I'm a visual person as well. So sometimes seeing the picture, it's easier to understand than using all this medical terminology or different words so the patient can understand it better. And I think they like that. And also like telling them that it's okay to make mistakes, but we're here to help them learn and get better. I see the growth from myself when I was a PGY1 here to now that I'm a PGY5 now. So I can see the growth. But so nobody knows everything at the beginning. If you know everything, then you shouldn't be in residency. You should be practicing already, I guess.
Do you, in that feedback session, do you ask feedback about yourself?
I do. I asked them what went well, what could have been better. And I asked them about my teaching style too. I asked them, is there anything that you wish I could do better? And I got feedback, and I think I have gotten better throughout the first year. At the beginning, I was like Dr. Sulove. It was more of like, oh my God, they might be missing something. So I was going in there and sometimes put it in orders. And now I learned to like, okay, I think this is my thought process. What do you think? Medicine is an art. So you can go in different directions. Just because that's the way I do it, it doesn't mean that's the only right way. So making sure they understand that and giving them why I'm doing a certain thing, or why we're not proceeding with a CAT scan where a KUB can be done. It's important.
Thank you. Dr. Sulove, when you have, and I believe now you have a new faculty, like brand new,
starting Monday.
Yes. What is the teaching, coaching advice that you could have for new faculty that are starting in this journey with the knowledge that you already possess?
So specifically, this particular faculty is or was already retired and is about to join again. So I am nowhere compared to him, of course. But yes, I do have the pleasure of working with people who have graduated later than me, and of course I can't teach them the way I teach or my style, but they very frequently see the things I do, which is every day or almost as much as I can, depending upon how busy the clinic gets. I hold a whiteboard session. And it is mostly a pop quiz. I give them a case to solve. And the case is somewhat related to one of the patients that we saw that day. And, of course, there are medical students and residents, first, second, and third year. And of course, the questions start with medical students about, how would they approach, what is their differentials, and so forth. And it goes higher up to the third year. And I just like to, see what their thought processes are, where they stand on a cognitive level before I give them, the long and short in terms of the full detail and how to approach those kind of cases. Sometimes those cases are even extremely rare cases that I have to read up before I give that talk, and which is almost always a 15, 20, 30-minute talk, depending upon where we are in terms of the day schedule. But that is something that I try to model for my co-faculty. But of course, I can only show them. I cannot really tell them, hey, why don't you do it? But yes, I think my colleagues are great, and everybody has their unique style of teaching. Everybody is well respected, very knowledgeable, and very nice to work with. And they have their own expertises. Like I think I do very well in bedside teaching and clinical medicine, and just physical exams, showing them how to do it. Versus there are people who would know population health better than me. So and that is really not my forte at all. So everybody has their own strengths and weaknesses, and we just go by and and do what we do every day, and give our little pieces of knowledge. We just hand them down to our residents.
Well,
Yeah,
I think that the job that you guys do is critical, is super important, and we're fortunate that you are doing what you're doing. Dr. Gross, how do you entice to new potential recruits, colleagues that are, no, I just want to be a regular hospitalist, see patients, and how do you go about not necessarily selling, but showcasing how proud you are of the work that you're doing, how much satisfaction it brings you?
Yeah, well, I'm absolutely a strong proponent, and I love my career, what I do. It's never too long or too much. I'm always happy coming in each day. And being here since the start of the program, we've seen a few graduate and stay with our system as hospitalists or in the outpatient setting. And definitely there are those that I see that I would love for them to be teaching attendings. I know for me, I wasn't initially confident. I thought maybe I needed a couple years of experience on my own before I could have a team with me and teach them. I was lucky that I started 1 year before the GME started, so I had 1 year of experience. But even that, I was thinking maybe taking another year. So I respect the need to kind of get a feel for things, become an independent provider, confident, competent care. But then, gently nudging them towards what I feel can be fulfilling with the different realms that you get to be involved with as an academic physician, that it's not just practicing, but it's teaching, and getting to perhaps help the hospital system through QI research. So I think you get to make more of an impact than just the person, not just the patient that's in front of you. You get to influence future physicians, and it's hard to think of how you can have a more positive influence in the population than that when you're influencing thousands and tens of thousands of future patients. So I definitely have my eyes on one current hospitalist that I want them to become a teaching hospitalist, and I think I might be able to get her to sway her.
What advice would you give a colleague, and it may already be a faculty that is hesitant or insecure of providing bedside teaching?
Yeah. So I know people have different training backgrounds. I was part of two huge academic institutions, University of Minnesota and Emory, and this was their standard practice. So I trained in it, and trying to think back, was I given any introduction into bedside teaching when I came here? And I don't recall that I was. Although I do recall with some new faculty them having an opportunity around with me, and for me to show them how I go about it. Again, I feel like it's essential to providing complete patient-centered care. It's not just simply fixing the issue and then discharging them, but yeah, you're there with the patient, telling them what's going on, telling them why this happened and what they need to do to help prevent it again. And there's really no other better way to go about that than directly with the patient, eye-to-eye conversation, making sure that you're speaking their language, their health literacy level, that you know their state of change, you kind of working with them with what they're willing to do and with what resources they have. So, for a new faculty or some faculty that doesn't do bedside teaching, I would encourage them to start doing it to begin with. And then I would say to get to know your learners beforehand as well, because it's a lot easier to get feedback when you have a good rapport with your team, so you can give harsh critiques and they can take it well. And then to think of key points to emphasize when you're doing bedside teaching, not to overwhelm them. And then giving the learners the opportunity to participate in the practice and to gain autonomy over time to learn the practice of medicine, which you're essentially teaching through your bedside rounding.
Excellent. Very good. Dr. Sulove, any brief pearls of wisdom for the learners as we close this?
Sure. So we have evolved, and from baby boomers till now, what Gen Alpha, but the learners probably are in the Gen Z still category. Lots of social media impact, lots of AI coming in. So of course we have to stay up to date, abreast with new technology. Unlike us, where we are so unlucky that if we study something in Harrison's, then we just have to make a mental picture of it, versus now they can Google image, and thousands of Google image are popping up. To use those technology to understand physiology, pathophysiology better. And, I always tell my residents to read basic books rather than just up-to-date. Up-to-date will give you a concept of how to approach the case and what is the evidence behind why the recommendations are so. But if you don't understand basic physiology, pathophysiology, microbiology, and pharmacology about those, then you will never be a great internist. You can be a so-so internist because you will probably want to go into a fellowship, which is great. But if you want to study general internal medicine and dedicate your life towards that, which I had always planned to do, then you need to know your basic sciences. And that is my basic pearl that I tell most residents almost every day.
Thank you.
You're
Dr.
welcome.
Munoz,
Yes.
same question, any brief pearls of wisdom for your learners?
Yes, of course. So I tell them to be a sponge and learn as much as you can. You need to make sure that you stay open-minded and that everyone has different styles of teaching. So adjusting sometimes to to the teaching style of the teacher, asking questions instead of making just when they come up with the plan. Instead of just do just whatever they're told, to make sure they ask questions, the why, and understanding why it's the behind it. I like what Dr. Sulove said about learning the basics of science is very important because that's how you're going to practice medicine. That's why what we do, like for certain medications, why are we doing this medication instead of the other one? Because we're learning about the pathophysiology, how is it working, the pharmacokinetics, and all that stuff. And I think that's important to know. And making sure that, like I said, they're asking questions and they're reading about the cases that they see in the hospital. I was I recently came with something about one of the psychologists that said that learners actually forget 56% of what they hear within an hour, and 65% in one day, and 75% in like 1 week, unless they actually revise the key points. And I keep telling them that, and that stuck in my mind because I was actually shocked that, okay, so whenever we have didactics, within that hour, the next hour, they have forgotten over half of what we have teach them. So I thought that that was interesting. So that's what I tell them. Make sure that you're reading and keeping yourself up to date and making notes and revising those notes every now and then, and making sure that you're ready for the next case when you see something similar. So, you know, like I said, medicine is an art and there's no right or wrong answer, but knowing why your thought process was not taken on the plan and why the other plan was better, it's important to know.
Very good. Dr. Gross?
Yeah, I wanted to expand upon the importance of asking why. That's the question I want to hear the most from my residents and students, med students. Kind of brushed over this, but yeah, through bedside teaching, one process is just going over your thoughts, discussing the case, and then you go into the patient room and apply that. But it's important to be able to think critically and ask questions and kind of be aware of biases. And I teach the evidence-based medicine class, which is to first-year residents, and I've been doing that the past 6 years. But yeah, it emphasizes how to think, not what to think. So regardless of what's in front of you, you can find the answer to that clinical question. And yeah, they're given skills for how to dissect all the different literature articles that we're responsible for interpreting and in turn applying to our patients. So I think can't underestimate the importance of that, showing them the thought process and then accordingly translating that to the bedside care.
Thank you. Thank you all for this wonderful discussion. Very timely, very key concepts that were highlighted. Patient-centered care, always asking the why, learn the patient, learn the learners, to be able to have efficient and efficacious bedside teaching. So this has been our podcast on bedside teaching, and we look forward to future ones. Thank you again.